Well, hi everybody. This is Dr. Jenny Peters, and I'm going to be talking about diabetes. So, as you probably already know and have taken care of numerous diabetics in your nursing career, diabetes is complicated, it's complex, and therefore I have a lot of slides. So, I'm taking these slides directly from the American Diabetes Association. They are the updated 2019 guidelines. They have fantastic slides and information on here. So instead of making my own, I am going to use these. I'm not allowed to alter them in any way, which is why there are so many slides. So I'm going to do this in sections. So it might help you so you can kind of watch it each section when is convenient for you and take a break. And I'm not one to read through slides either because I know you guys can read slides. So I'm going to do the best I can to just give an overview of what's on each slide and add some anecdotal information in addition. So this first part here is just an overview basically of the guidelines. There's 12 slides on here. So I'm just going to start this here. All right, and this screen just says that we're not allowed to reproduce it. And this is from the Standards of Medical Care in Diabetes of 2019. You can get that online on the ADA website. You can print it out. I'm not sure if you can order copies, but that probably is an option. I have an article that I will make sure that Dr. Parvi gets it uploaded so you don't have to worry about that. Now, these are the standards, and how do we determine what the guidelines are? Well, we have evidence, and then we have committees that go through and make sure that this evidence is from really good studies, and I'll show you a slide in a minute. And then also we need funding to do this too. So it's out of the American Diabetes Association to make these guidelines, and it mentions it does not use any industry support. So there's been some recent changes more in process because with technology and so many changes in diabetes care and medications, there's a lot of things that they need to look at continuously. So what they did is making it more online so you can update it frequently. The organizations and the committees can do that. And now what they're doing is taking proposals from the community, which is kind of nice because it's not just specific organizations that they take comments from or proposals. And now it's going to be from the community, consensus reports, scientific reviews, clinical and research conferences. All right, so also this is a living document, meaning it's a live document. So there's always might be updates to this. And when they're going to make an updates is if there's approval of new medications, specific devices, or if there's some research that came out that supports a change or recommendation, or the evidence level of recommendation, which I'll show you an evidence table. All right, so this is the evidence table. You should have seen this by now for evidence-based care. Now remember levels A, B, and C and E. And level A is the best, so it comes from really well-designed randomized control double-blind studies usually. So that's good. And then level B are also really good studies. Those are usually cohort perspective or analysis of a specific population. And then C is more of a poorly controlled study, so it's not that they're not recognizing it as a study. They would put a recommendation, but then they'll also say, well, it was a C, so maybe it wasn't a well-designed study. These are all the table of contents. So like I said, I'm going to put these into different slide sets for you and videos, so it'll be helpful for you. All right, so section 1. This is general, just how are we going to care for the population and some statistics. A lot of people don't meet targets for their A1C blood pressure or lipids. And just so you know, there's a high percentage of people that are walking around that are not diagnosed with diabetes. They're not diagnosed with prediabetes, and they already have it. Metabolic syndrome is one condition that is underdiagnosed. And so I'm going to really emphasize that. As I started with metabolic syndrome, so I will tell my story as I go through this. And I'm not your typical person that you'd see with metabolic syndrome. So meaning that my BMI has always been under 25, and I've never had an issue really with my weight. So I will go through that story and tell you, and I want you to be aware that not all diabetics are overweight. And even I'm talking type 2. We know diabetics that are type 1, we usually will see them more on the underweight side or thinner. But type 2, while typically we do see it's a weight issue and insulin resistance, you can be of a normal BMI but still have some insulin resistant issues. There's some genetic components. So as we know that people aren't meeting the targets, there's a chronic care model that we're trying to change to prevention. Now, we can't prevent once diabetes is diagnosed, but we want to try to prevent diabetes in the first place. But this chronic care model, we're trying to get more of a proactive care delivery rather than being reactive, because our society, and it started over a century ago, of becoming reactive due to all the infectious diseases and illnesses and then antibiotics. So it is reactive society. Also, how are we making decisions? And we need to make sure that these registries are up to date, because that's going to help us gather data to determine whether treatments are working or whether they're not working, as well as community resources in every single city, every single neighborhood. It starts with us, it starts with our community. So population health is really important. And this brings me to diabetes and population health. We need to work as a team. And this is what this slide basically says. We cannot do this alone as providers. We need to work together with people externally, out of the office, out of the hospital, and out in the community. And I tell the patient that you are with me for 30 minutes. Let's just say, for example, every 3 months. You are in your own environment for the rest of the time. So we need this to be a team effort on the patient's part also. And this talks about social context, where we, as I said on the last slide, to refer to community resources. And also, we should also not just only provide on professionals. Are there family members? Are there other people that do have a lot of wisdom and knowledge about diabetes? So let's not underestimate the lay population that may know more than what we think they know, and we can educate.